Thank you, Isabel, and thank you for inviting me to speak. I'm going to speak in favor of AF ablation as a method for preventing stroke. So these are my disclosures. Probably the most relevant one of those is that I ablate AF, so this will definitely, well, not definitely, I'll try my best to be as balanced as possible, but it will influence my thinking. So before I go through my slides and present my case to the audience, I'd like to know what you guys think. Instinctively, ignore what you've read and what other people tell you. What is your instinct? Do you think an AF ablation can reduce somebody's risk of a stroke? And we can do a show of hands. So yes? Okay. And then no? Okay, I think slightly more no's and a few undecided people there, but let me convince you otherwise. So I'm going to go through this pyramid of evidence, starting with randomized controlled trials at the top. And then beyond that, we have subgroups of randomized controlled trials, observational studies, and then I'm going to go on and talk about something called the Bradford Hill criteria, which some of you may have heard of, but it's a useful way of thinking about these arguments sometimes. So has there ever been a randomized controlled trial to assess whether AF ablation versus medical therapy reduces your risk of a stroke? And the simple answer for that is if the primary outcome is does it reduce your risk of a stroke, the answer is no. That's not the end of the argument, though. There have been a number of other randomized controlled trials which have tried to investigate. Probably the most high-profile one of those is going to be Cabana, but disabling stroke was part of a composite endpoint, which included all-cause mortality, serious bleeding, cardiac arrest as well. And this was presented at the Heart Rhythm Society Congress last year. And as many of you will be aware, the outcome for the intention to treat analysis, what it was that it was negative. Another trial, which has now completed enrollment, but will be hopefully presenting in the near future, is the trial called EAST, which again looks at stroke as part of a composite outcome, which includes cardiovascular death, stroke, worsening of heart failure, and myocardial infarction, and the results for that are awaited as well. So the question is, we've had these two big trials, one of them hasn't worked, will there ever be a trial which looks at stroke as a primary endpoint for AF ablation? And if you compare other successful interventions in cardiovascular medicine and look at the relative risk reductions we've achieved with those, secondary prevention, statins, 25% relative risk reduction, primary PCI versus thrombolysis for STEMI, about a third, primary prevention ICDs for mortality, about 27%. So these are figures from various meta-analyses. So probably, looking at those, you'd probably want to go for a 30% reduction in your relative risk of a stroke from an AF ablation. So how many patients do you think we'd need for a randomized controlled trial? So this is both arms combined. Votes for A, 400. B, 800. C, 1,500. Okay, we've got a few votes for 1,500. D, 4,000. Getting more popular. And E, 10,000. Okay, so we're kind of between the D's and the E's. So I got my statistical colleagues to give me a hand with this. So let's say, so in EAST and from the edoxaban trial, Engage AF, even with good anticoagulation, the annual incidence of a stroke was about 1.5%, roughly, in both arms. So let's say we stick with that annual incidence of a stroke. We run a trial over 4 years. We aim for our 30% risk reduction, go for 80% power, and alpha 5%, which is fairly standard. You'd need about 3,700 patients, which is bigger than Cabana and EAST. The other thing to note about Cabana is that there were a whole load of crossovers. About a quarter of the patients crossed over, but these were very symptomatic patients, so maybe we have a slightly less symptomatic group of patients for this trial. We'd still go for about a 20% crossover rate. That would require about 5,800 patients, so that's almost double the size of any existing trial of AF ablation. As I said, Cabana only 2,200 and EAST is 3,000. So we need a trial bigger than anything we've held before to show a relative risk reduction, which would be as impressive as things like primary PCI and ICDs. So even if it did work, and it worked really well, we would need a huge trial just because contemporary anticoagulation is pretty good. So where will we get the answer from at all? East could tell us, but as I said, it's only part of a combined endpoint, so not for the foreseeable future, but it doesn't mean it doesn't work, and I'm going to argue why it may do. So where else can we get the answer from? So we have subgroups of randomized controlled trials. So Cabana did look at disabling stroke as one of its subgroups, and in the intention to treat arm, there were fewer strokes in the ablation arm than in the medical therapy arm. But look at those percentages, 0.3% in the ablation arm and 0.6% in the medical therapy arm. So these incidences were very low. This was non-significant, but again, it wasn't powered for it. And actually, this was much lower than the 1.5% we were speculating about the trial we could set up to look at this question. The East trial, we could look at subgroup data, but the results for that are awaited. So what does that leave us? That leaves us with observational studies. And observational studies, ideally, you want with the control to see how much better it is than medical therapy. And ideally, you want the subjects to be in the control arm to be matched as well as possible. And with this, there have been a huge number of studies, and I can take you on a journey around the world where they've been done. So we can look at registry data from Sweden. This is probably the most recent of the observational studies. They did a propensity match score. They matched the patients with 51 different characteristics. We have about 5,000 patients, so that's not far off our presumed trial. And we have a hazard ratio of 0.69. And if you look at the Kaplan-Meier curves, there's a very impressive wide separation. This is data from one of my previous colleagues in London who looked at observational registry data from the UK as well. And again, we see a similar effect. We see a 0.64% annualized stroke rate out to 5 years with pulmonary vein isolation versus 1.84 with a matched general AF population. And there's been some analysis of stroke incidence in the years prior to the ablation procedure and the index visit for medical therapy for AF. Again, the combined data from Australia and the UK by one of my current colleagues, again, an impressive benefit from AF ablation. These patients weren't matched, and actually the patients in the medical therapy arm had more risk factors. But again, we see a 0.6% annualized risk of stroke in the ablation arm with a strong p-value. Similar studies have been done in other parts of the world as well. We see similar hazard ratio from this study in Israel. Again, large numbers of patients, 3,000 controls, almost 1,000 patients in the ablation arm. Again, a hazard ratio of 0.61. People with a CHAS-VAS2 score of greater than 2, so high-risk patients in the majority of cases. Similarly, there's a smaller propensity match study done in Taiwan in 2012, which again shows an impressive reduction in the stroke rate in our ablation arm versus the control arm. And similarly, in the States, the team in Utah have done a number of studies over the years which have looked at age and sex match controls with similar CHAS-2 scores. The people who have an AF ablation have a similar stroke risk to people who don't have AF at all, and you can see almost double the risk of having a stroke if you have AF with no ablation. And they've similarly done an analysis more recently on people who've had a stroke and have then gone on to have an AF ablation. The risk of a recurrent stroke is similar to people who have not had any AF at all. Versus people who haven't had an AF ablation, who are managed medically, their hazard ratio is almost double of those patients. So there's a huge amount of observational data out there, but as you know, observational data is observational data. It's not the highest form of evidence available, and there are a whole number of caveats. And many ablaters who may be in the audience know when you do assess your patients, there probably are a whole number of subconscious factors which you take on and absorb before you put a patient on the list and consent them for an AF ablation. And some of those may even confer people who have a slightly better risk profile. These things are very hard to capture in any sort of analysis. No amount of propensity matching can correct for that. And until we do this mega trial of AF ablation, we're never going to know for sure. But if you can see, all of those studies from around the world, done by a whole range of different people in different countries, have all shown a very strong effect to suggest that AF ablation confers a protective benefit if you do big registry studies. So we can look beyond the registries as well and think about this in a slightly different way. And I've used something called the Bradford Hill criteria. So this is a technique which the epidemiologists use, and it was designed by an epidemiologist called Bradford in the 1960s in the UK, and he came up with 9 criteria to provide evidence of a causal relationship between a presumed cause or an intervention and an observed effect, and often these are used as a prerequisite for performing a trial, and its use have evolved over the years. But I've tried to apply these to AF ablation and see whether we can use this to try and help guide us as to whether AF ablation might reduce your risk of having a stroke. So the first is strength. So in the case of AF ablation, if we did an AF ablation, we'd see a massive reduction in stroke risk. As we see from our numbers, which we've discussed so far extensively, that's going to be very difficult to describe. Consistency. So are these observational early data reproducible? Clearly, we've seen that. There have been registry studies from around the world which have all shown this fairly consistent effect. So specificity, how specific is your intervention or your putative cause in causing this disease? Well, I think if you're doing an ablation to get rid of AF, that's pretty specific, so I don't think that's particularly relevant in this argument, but it's correct and it's there. Temporality, so does your stroke risk drop after having the AF ablation? And we've seen from that observational study from the United States that there's a suggestion that that might be the case. Biological gradient, is more of this risk factor going to give you more of a stroke risk? And we've seen Dr. Van Gelder's talk earlier about AF burden and stroke risk. So there we have evidence to suggest that the more AF you have, the greater your stroke risk. So therefore getting rid of that AF may reduce your stroke risk. It's part of this broader argument, but doesn't necessarily stand on its own. Plausibility, does it make sense? If you get rid of AF, do the mechanistics and the biology of it all make sense for you to reduce your risk of having a stroke? So if you reduce the amount of AF a person has, you may improve the mechanical function. So in theory, you may reduce the mechanical causes, which may increase your risk of forming a clot. Coherence, do other in vitro findings support your findings? I think this is difficult to know. I think this is an experiment which could be done. We've heard about how AF patients, beyond the mechanical effects of being in atrial fibrillation, have an increased tendency for thrombogenicity, and certainly some in vitro studies could try and help understand whether AF ablation reduces that. Experiment, well, that's the ultimate answer. We're awaiting our randomized control trial. We're awaiting EAST. We know that doing a randomized control trial where AF ablation looks at stroke alone will be very big and very difficult to set up, and certainly nobody appears to be doing this at the moment. An analogy, is there a similar intervention or a similar cause which has a similar effect? And I think the best analogy we would have would be medical therapy and stroke risk. Probably the best example we have is the AFFIRM trial, where we saw that when rate control was measured against rhythm control with medical therapy, there was a neutral effect on prognostic outcome. But when a post-hoc analysis was done, it was found that actually a lot of the benefits of being in sinus rhythm were negated by the adverse effects of the side effects of drug therapy. And once those are taken out, it suggests that sinus rhythm confers a benefit, a prognostic benefit. So all these things on their own are relatively weak, but they form part of a wider argument. What's probably more convincing is the data from these multiple observational studies from around the world, which show that actually AF ablation can really reduce your risk of having a stroke. So on that note, I will conclude. Can it? Yes, I think we just need to do a much bigger trial to prove it. Is it worth it? Well, anticoagulation is pretty good. The absolute risk reductions over 1 year might be small, but actually if people have a lot of years ahead of them and you're doing a successful procedure, then actually over their lifetime, the benefit might be quite important. And I'll stop there.